Hello, everyone. I am Justin Anderson, Dartmouth's Vice President for Communications. I'm pleased to be with you today to talk about a subject I suspect we've all heard about, but still don't know a ton about. That subject is monkeypox. According to the CDC, the monkeypox virus is part of the same family of viruses that causes smallpox, with symptoms that are similar but milder and rarely fatal. So that's helpful, I suppose, but rather than relying on my Google skills to educate or miseducate us on a global outbreak, I am fortunate to be joined by two Dartmouth physicians to help us understand monkeypox and answer questions that you in the community have. Our first guest is Dr. Elizabeth Talbot. Dr. Talbot is a professor of medicine at the Geisel School of Medicine and the deputy state epidemiologist for the state of New Hampshire. She's an expert in infectious diseases, and so, given all these roles, she has been closely tracking the monkeypox outbreak. Dr. Talbot will give us a presentation on the disease, sharing her expertise and what we currently know about this latest global health issue. Following Dr. Talbot's presentation, we will hear from Dr. Anne Bracken. Dr. Bracken is an assistant professor of medicine and pediatrics at Geisel and the director of clinical medical services and a staff physician at Dartmouth Health Services, or Dick's House. As such, Dr. Bracken can tell us about the monkeypox response and resources to students on Dartmouth's campus. At the conclusion of their presentations, I will relay questions from the audience, your questions. So please, as you have questions throughout the presentations, please enter them by clicking in that little Q&A icon at the bottom of your screen. I will do my best, I promise, to get to as many questions as I can. So with that, and without further ado, I'd like to introduce Dr. Elizabeth Talbot. Dr. Talbot, please take it away.
With pleasure. Thank you very much for the introduction. I will use slides to keep me on track and try to stay as clear as possible on the emerging science here. So these should take approximately 20 minutes, and I do welcome questions in case I've missed something that you're interested to know. I'd like to start with a statement that we've all suffered loss during the last 2 years and 8 months with COVID-19. And just as we're moving from that emergency phase into efforts to live with it, now we're hearing about monkeypox. It's a cruel blow, cruel timing. As said, monkeypox virus is an orthopox virus, that is, a group that includes the smallpox virus. It's a fairly recent history for this virus. It was discovered in 1958 after there were 2 outbreaks in groups of research monkeys housed in laboratories. This is why the virus was named monkeypox, even though we need to recognize that's a misnomer. The name is promised to be changed, and from my side, it's none too soon. It is naturally occurring. It is so-called endemic in parts of West Africa and the Democratic Republic of Congo, where the actual reservoir, where it survives in the environment, is believed to be rodents. It's currently spreading rapidly through dense sexual networks, almost exclusively among men who have sex with men, or the abbreviation well known as MSM. I want to bring to you today the news that there are effective prevention strategies and a useful treatment that are readily available should need arise. So, how has monkeypox historically moved in our human population? As an endemic sylvatic zoonosis, the rodent reservoir and occasional human contact where a person becomes infected, it had been thought and observed in endemic settings, as shown in the map of Africa, that sustained human-to-human transmission was unlikely and rare. In recent past, we've noted some limited outbreaks such as actually in the United States. In 2003, there was an outbreak of monkeypox that was related to direct or indirect contact with infected animals. These animals were part of the exotic pet trade. So people who imported Gambian giant pouched rats from Africa, from actually the endemic zone, in order to have unique pets. So this is not a new virus. We certainly have known about it in infectious disease control and epidemiology. The current outbreak, however, is unprecedented. There have been multiple introductions from Nigeria to non-endemic countries, countries that don't normally have this disease circulating among their animals. It's genetically called clade 2B, previously called the West African strain. We're watching closely recognition that this particular outbreak strain has evolved to be more suited to human transmission, in contrast to what I described for the endemic strain. So infections are increasing globally and in the US. So globally, there are approximately 38,000 cases recognized as a gross underreport given availability of testing and access to care. And the US has now become the most single burdened country globally with more than 12,000 cases. The other heavily impacted countries are Spain, Germany, UK, Brazil, and France. But as you see, the US has far outpaced those countries, and the slope of our epidemic curve is somewhat alarming. In recognition of these events, the World Health Organization declared on July 23rd that this outbreak is a public health emergency of international concern. That declaration provides some resource and international attention toward control. Investigations are showing that spread of monkeypox is occurring largely in networks through male-to-male sexual contact. Indeed, there have been no deaths from monkeypox reported in the US to date. This graphic on the right shows some deaths globally as part of the outbreak, but I draw your attention to the fact that the scale of these y-axes are different. So in this, we've made mention of more than 35,000 cases, but here the number of deaths is only about 12. However, disease, albeit mild, can be significant. The rash that's classic for this disease can cause significant pain, especially on mucous membranes, such as in the mouth or perirectally. There can be complications of having open skin lesions, such as secondary bacterial infections, where the bacteria that live normally on our skin can take advantage of the rash and enter and cause diseases like cellulitis or abscesses. And then we are understanding that people who come through monkeypox, who survive it, who do recover from it, can have scarring that is disfiguring or even disabling. So a very serious disease, to be sure. This graphic is from our Centers for Disease Control, the Public Health Authority in the United States, and shows by virtue of the size of the circle where the heaviest outbreak is. So of course, the US, as already stated, has the largest circle on this global map. The yellowish colored circles are countries that have not previously had monkeypox circulating, non-endemic countries. And the blue are those that are familiar with this disease because of the reservoir in rodents. Those numbers shown here, more than 37,000 cases in 86 countries that had not previously had other than sporadic introductions of disease, and 387 cases from the endemic countries. Again, a gross underestimate given lack of availability of testing. A closer look at the US map shows the most heavily burdened states are New York, Florida, Illinois, Texas, and California. In New Hampshire, we have 15 confirmed cases. Vermont has 2, Maine has 3, and Massachusetts is far out ahead with 228 at last count. Putting on my hat as the Deputy State Epidemiologist, we have been intentional that the goals within our public health response are containment and prevention. Containment refers to responding to those who have confirmed infections. We want to do testing for people so we can identify those with infection. We want to isolate and treat those with confirmed infection, identify contacts to those confirmed cases, monitor, not quarantine, people who have been exposed. This is really different than we had to become used to for COVID, because persons who are asymptomatic cannot transmit this disease. So we don't quarantine people, but instead we empower them, enable them to report promptly should they develop symptoms after an exposure. Containment also has some role for vaccination of contacts, that is so-called post-exposure prophylaxis. We're going to come back to that concept. We're also looking to prevent. We're increasing awareness and creating tools for risk reduction counseling, for example. We're having community meetings and trying to promote these public health messages on social media. We're vaccinating at-risk persons to prevent disease before exposure. This we'll go forward calling PrEP, pre-exposure prophylaxis. So we need to know who's at risk for monkeypox. There have been now multiple studies from several jurisdictional outbreaks. There's a large report from the entire European Union and then several members of the European Union. The US has reported on its first 305 cases, and there's been a global report from Sentinel countries that participate. The features of cases are remarkably similar. 97 to 99% of confirmed cases have occurred in cisgender males reporting male-to-male sexual contact. Some report sexual risk factors such as multiple new partners, anonymous sex, or having sex on premise at sites like bathhouses, saunas, and other such sites. 30 to 40% of cases globally are HIV infected. There have been sporadic global cases reported in households, non-sexual contacts, heterosexual contacts, and young children who are in households with confirmed cases. This leads us to a message that although the current snapshot is this predominance in men reporting male-to-male sexual contact, any person, regardless of gender identity or sexual orientation, can acquire and spread monkeypox. Symptoms in the current outbreak are mild flu-like illness that may precede rash. So this is headache, fever, feeling tired, muscle aches, and typical non-specific symptoms. 2 to 3 days after that, a rash begins. This could be scattered, diffuse. It's sometimes limited to one part of the body, including the mouth or oral mucosa or anogenital region. The lesions may be in different phases of development. That is, some are maturing, some are healing. Presenting complaint may be anorectal pain where there is not even awareness that there's a rash present. And then one other consistent theme emerging in the global analyses of cases are that many have more than one infection at the time of presentation, such as with sexually transmitted infections, gonorrhea, chlamydia, syphilis, and the like. A closer look at the rash. These are unique lesions. They are firm and deep-seated, is the phrase we're using. This is in contrast to fragile superficial rashes like chickenpox, also known as varicella. These are well circumscribed, meaning you can see that they're really in the appearance of a circle, and then sometimes umbilicated. The small graphic here gives an example of a lesion that appears umbilicated, that is with a central crater as it matures. And these lesions progress through various stages of development from small pimple-like lesions, sometimes to larger ones, as in the child's hand, and then through a stage of scabbing, and the scab falls off. How do people get it? So transmission, when it's human to human, this virus enters through broken skin, the respiratory tract, or mucous membranes. In some cases, transmission seems to occur through close, prolonged hours of face-to-face contact. through spread of respiratory droplets. It is not an airborne disease. That is, if there was someone with monkeypox in a room and you enter the room after that person has gone, we have no evidence that that can transmit disease. There is, however, the possibility of transmitting through direct physical contact with a confirmed patient's body fluids or rash, or indirect physical contact, meaning contact with something that's contaminated with rash material or fluids. So this is how we believe that many of the household contacts of confirmed cases have been occurring, handling linens, towels, and the like. This is a disease we can test for with great confidence. Testing can be conducted on swabs of skin and these mucosal lesions, and any healthcare provider can collect. This is not something you have to go to a specialized center to have testing. Once collected, the swabs are sent to a lab that's specialized for PCR testing for this disease. Right now, there's the public health laboratories in each state, but also there are 5 nationally commercial labs that are able to do this testing. Public health will call every person who tests positive to assess their need for treatment and enable them to be safely isolated. Part of that public health call will also include identifying the patient's close contacts in order to connect them with vaccine to prevent infection or treatment if there's somebody at high risk for bad outcome from disease. Even if a healthcare provider just strongly suspects monkeypox because of that, the features of acquisition known to date and the appearance of the rash, before the test result comes back positive, they can still take actions even before that test comes back to them with a positive result. Who should get tested? Any person with an illness consistent with monkeypox as described, or any person with a rash that might be monkeypox. That is, it doesn't look necessarily classic, but they also have these epidemiologic risk factors I've described to you. There's a lot more information about this on the CDC's website and through lots of good public health resources out there. I find it greatly reassuring, I'm sure you do too, that there are medical countermeasures. That is, we have tools in the toolkit for both prevention and treatment. I'm going to mention 2 of them in brief because I'm sure you're seeing these names in lay media and I want you to have a deeper dive on them. One is the Jynneos vaccine. This is a vaccine that was developed for smallpox. And then treatment, that is, somebody who has disease can be treated with an antiviral called TPOXX. So this Jynneos vaccine is a live virus vaccine like the MMR or the chickenpox vaccine, but it's not able to replicate. It can't divide and disseminate itself in the person who's vaccinated. It is the only FDA-approved vaccine for monkeypox. It's approved for adults and can be used in children if needed. It's a 2-dose series where the doses are separated by 4 weeks. It can be used if somebody has been exposed to somebody with confirmed monkeypox, that's the post-exposure prophylaxis, or because they engage in risk behaviors that may make them vulnerable to getting disease. That's called pre-exposure prophylaxis. We think it's an effective vaccine based on historic smallpox vaccine data. The Jynneos vaccine seems to be at least 85% protective against getting monkeypox. So when used after exposure, the appropriate people to get the vaccine is anyone who had close prolonged contact or direct physical intimate contact to another person confirmed with monkeypox. It's also appropriate to consider the Jynneos vaccine for a person who comes in physical contact with items like clothing, linens, the environment that previously touched the infectious rash or body fluids. The timing for vaccine is the sooner the better. If it's able to be given within 4 days of that exposure, it may prevent any manifestation of disease. If it's given later than that, but certainly within 14 days, it may reduce the symptoms and the severity of disease, but probably won't prevent disease altogether. In that other category of the utility of the Jynneos vaccine, who should get it before they've had any exposure? The persons who work in the laboratory, either to care for clinical samples or those who are doing research on viruses like this, those people should get it. There are certain healthcare and public health response workers who also should get it. But the majority of interest in the current weeks has been for those who are at high risk of acquisition through their social networks. So in New Hampshire, we're recommending to get this vaccine to those men who have sex with men, including persons who are assigned male sex at birth, and transgender men who engage in high-risk sexual activity. Examples of high-risk sexual activity are 3 or more new sexual partners in the last month, engaging in group or anonymous sex, engaging in sex with others at sex on-site venues or events, people who exchange sex for money, drugs, or services, and the group of people who are currently prescribed medications for HIV prevention. This is called HIV PrEP, and that's often a surrogate for some of those other sexual risk factors. You can get this vaccine in New Hampshire. Our website linked here is active, it's dynamic, it's changing. If you hover over the site closest to you, you'll see a pop-up that will allow potentially scheduling access information on how to get the vaccine at site. You'll see Dartmouth Health, that is in Dartmouth's neighborhood, is coming soon. We have been giving some vaccine, but we are not right now open to public registration. I think really in just the coming few days that will open up. I wanted to reassure you too that we have treatment for those who have disease. This is called tecovirimat, but for short, I'll call it TPOX. It's FDA approved since 2018 for the treatment of smallpox, monkeypox's cousin, in adults and children. CDC holds an expanded access investigational new drug protocol that'll allow us to get this for either confirmed or suspected disease as early as possible, particularly in those who have risk for progressing to more severe types of disease. The eligibility for this is when there's a high suspicion, clinical presentation consistent with high risks that are reported, and treatment can be started even before those results returned. The only people who can't get it are those who don't want to sign the informed consent, which is required, or who have a known allergy to this treatment. There are some caveats that clinicians are aware of, such being careful with people whose kidneys don't work well, but there is an oral option that is safe for those folks. So with that, I want to transition to more local information for you, and it's a pleasure to transition to Dr. Ann Bracken, who will be able to tell you some of the fine work that's been going on at campus. So with that, I'll stop my share and hope we'll have time for questions.
Elizabeth, thank you so much. That was an excellent presentation, as usual. We have been able to work with Elizabeth for several years now, as her role prior, she was the state epidemiologist and then also an infectious disease doctor at DH. And we've worked with Elizabeth on mumps and tuberculosis, COVID, now monkeypox. And we're really grateful to have her expertise. And you can see that she really is super well informed and such a great resource for us. And thank you for continuing to be available. We thought we would just talk a little bit about how we will manage monkeypox on campus. Currently, we have no cases. And so this is information for students, for families, for community members about how you might make a referral if there's concerns. So at the Dartmouth College Health Service, we see the students. If students have concerns about either an exposure or a concerning rash, we have a 24-hour nurse advice line. And we also have providers on site from 8 to 4 during the summer hours and 8 to 4:30 during when the undergrads are here for the fall, winter, and spring terms. And we have nurses on site 24/7 during the undergrad terms as well. So there's a lot of availability for help and triaging concerns. We are happy to do telehealth visit or in-person visit. We have a site, we have the the health service at Dick's House, located at Dick's House. We also have a site right next door where we are evaluating students with COVID and can see students with concerns for monkeypox too. Elizabeth mentioned the testing. We can test here on site. It's very easy to do. We would send our tests to, we have all the materials already. We'd send those tests to the state of New Hampshire, and there's a 24 to 48 hour turnaround. So we anticipate hopefully that we would get a test result quickly. We will advise students about quarantining while they're waiting for that test result. Should a student test positive, we have isolation housing identified on campus. So students who are enrolled for the term and have a residential spot on campus would be eligible for this isolation housing. We can also support students with dining, medical care, and then support them related to academic accommodations. So one thing Elizabeth didn't mention is that if a student is in isolation for monkeypox, it's possible they could be in isolation for 2 to 4 weeks, which is quite a long time, particularly for a Dartmouth term. And we acknowledge that that's a big hardship. We had students in isolation during COVID, and that was stressful. This could be a longer isolation. We're going to work with students related to providing the services they need, but also working with their deans and providing academic accommodations as possible, as we would with any kind of prolonged illness that a student might have. Elizabeth mentioned that contact tracing. So if we identify a case, we will work with the state related to supporting the state to do the contact tracing they need to do. And then when the state is doing that contact tracing, and we're happy to provide names and work with the students, those students will be monitoring. The state will be communicating with the students, but we can also help the state with that contact tracing and with the support of students who are known exposure. Now, Elizabeth mentioned that if you are exposed, that there's the vaccine, the Jynneos, that's available, and that New Hampshire has several sites for that vaccine. So there's the category of the post-exposure prophylaxis, and then the pre-exposure prophylaxis. Both of those categories of students could access the vaccine, and we can help to support them in either category. We already have developed a referral form, so the post-exposure would be known contact, often intimate contact or very close personal contact with someone or with their linens or clothing. And we'll help to sort out with students and with the state, they'll help to sort out whether you're actually a contact or not. And then, as Elizabeth mentioned, getting the vaccine within 4 days is optimal. Then we also have a category of students who are pre-exposure prophylaxis. So Elizabeth had mentioned the high-risk group. We have a number of students who are men who have sex with men on campus and who take PrEP, HIV PrEP, which Elizabeth had mentioned. That's one of the categories. So students who take Truvada to reduce risk of HIV, they're eligible for the pre-exposure prophylaxis with the Jynneos vaccine. And we've already had several students come to us. And we know one student already has an appointment to get their Jynneos vaccine in the state of New Hampshire. So the system is working. We're really excited about that. And we'll be working closely with the state to support students who are at high risk for pre-exposure prophylaxis, and also students who have a post-exposure, hopefully to get that vaccine within the 4 days of that window of exposure. Another thing is treatment. Elizabeth mentioned treatment. And again, we have Elizabeth, we have our infectious disease doctor specialists at DH who will work closely with, as well as with the state, to identify those students who should need treatment for monkeypox. We also have a website on the Dartmouth College Health Service, has a website with a monkeypox box, and people should feel free to visit that website. The New Hampshire website is excellent. It has the map where you can find out, okay, 15 cases today in New Hampshire, 2 cases in Vermont. What are the cases across the country? There's also information about the vaccine. There's information that the state releases, the New Hampshire, the Health Alert Network memos. So they've already released 3 memos related to how the state's going to manage monkeypox. Those resources are on the website. We also have resources from the CDC on our website to help reduce risk for our student population. And so that might mean, how do you have safer sex? How do you manage close contact in big social events? We're also thinking about our athletes who play contact sports. So we're going to try to do some prevention work on campus. And as Elizabeth mentioned, the state is also working to identify people who would be eligible for the PrEP and also to reduce risk in general to practice safer sex habits so that we might reduce the incidence of monkeypox on campus. Right now, we have no cases of monkeypox on campus. And then the last thing is, I think people will feel, we're so grateful to Elizabeth, and that I hope people will feel confident that we have the resources, we have the state, we have DH, and we have had the practice with managing COVID in terms of the infrastructure on campus to help support students. So with that, Justin, I'll go back to you for any questions that people have.
Thank you, Anne, and thank you, Elizabeth, for that informative presentation. We are receiving some questions, and interestingly, but perhaps not surprisingly, they're mostly all about vaccines. It seems that vaccines are top of mind for all of us for a variety of reasons. We've been thinking about vaccines for the last couple of years as sort of the thing that we need to get back to normal and to stop being terribly concerned. And so I guess it makes sense that lots of people are asking about vaccines, and there are some good questions here. One, should faculty and staff at Dartmouth, and I suppose by extension everyone, get vaccinated for monkeypox? And I'll let either of you handle that. I'm sure you both have a take on that.
Maybe I'll start and you can follow if it's all right. My perspective is, in this current state where there's limited vaccine and the risk factors are so clearly clustered in a certain population, that persons who don't have those risk behaviors don't need to access vaccine. So it may be that this virus gets into the general population or is spread through heterosexual sex more commonly, and then we'll change these recommendations. But the snapshot today suggests that there's not need for widespread vaccination of persons who aren't in those high-risk sexual categories.
And I think you certainly implied an answer to this question, but I'm just going to ask you to be specific, at least as the current plan dictates. So will Dartmouth receive a supply of the vaccine, or will community members have to go to one of those spots that Elizabeth pointed out on the map?
Well, both community members, so faculty and staff, would use those sites, and students currently will also use those sites. So we will shepherd the students who either fit into the post-exposure prophylaxis category or the pre-exposure prophylaxis category and refer them to those sites. But on our website, so anybody can go to look at our website or the New Hampshire website to see the indications, the eligibility, and then where they can call to if they fit into those categories, particularly staff and faculty, community members, and then we can help the students too.
Elizabeth, this is a question that is for you. It's a good and interesting one. New Hampshire was for a time reporting new monkeypox cases at rates that mirrored national and global new trends, showing exponential growth. New Hampshire has not reported any new cases since announcing a cumulative total of 15 on August 7th. What do you think explains this sudden change in the trend of new cases being reported in New Hampshire?
My suspicion is that the message is getting out, is that people are recognizing that this risk factor is one that needs to be taken quite seriously. So whether there's a reduction in risk behavior, I believe that's the main answer. In fact, some of our initial cases had been reporting that they traveled to Pride events, for example, and some of these so-called super spreader events in Europe. Those are over now, and I think the message is getting out. So that's my hopeful answer to why we've been, if you will, stuck on 15 for a while.
It's good. Sometimes it's good to be stuck. Let's stay stuck. Um, not surprisingly, again, a lot of questions about contagion, particularly relevant at a campus like Dartmouth with congregate living. There obviously are different areas around campus that are sort of highly populated. And so does the risk of contagion sort of go up in a meaningful way, say in the dining hall, or at a crowded party, or in a classroom? How does the level of contagion or the risk of contagion differ in different settings, particularly as those settings get more crowded?
I think COVID has made us all very savvy about the way infections like to transmit. And I will say it again, that this is a virus that wants predominantly to circulate through intimate or sexual contact, particularly MSM. There have been those sporadic cases of persons who are heavily exposed to lesions, lesion material, contaminated surfaces or substances. But that's not the predominance. All of those cases, as described in previous graphics, almost all of those cases were resulting from sexual and intimate contact. That said, when someone has an infectious prodrome, somebody who has been exposed to monkeypox, they're coming down with disease, they're at the stage of fever and feeling unwell, they can be contagious. Or someone who has lesions, who's having skin-to-skin contact with someone in, for example, a crowded dance or rave or such, there have been cases of transmission in that route. So it's all a matter of grading risk, highest risk from high-risk sexual behaviors. Otherwise, it's transmissible through other mechanisms.
I'm going to actually stay on this issue because a question just came in, sort of a follow-up that I think is a good one, and it's about children who have been diagnosed or have developed monkeypox. Could this be a problem in daycare centers, Dartmouth daycare, or in local classrooms, where obviously, you know, those of us who have kids know that kids are on top of each other. There's plenty of skin-to-skin contact because they're all over each other. And so, is that a realistic risk that we should be thinking about?
I think it underscores the importance of keeping home when you're ill. Anytime, you know, you have a fever, you have a headache, you don't feel well, you should stay home, and then protect your family from that. We've all learned these hard lessons from previous outbreaks of potentially respiratory transmitted diseases like COVID or H1N1. So it's hard when the question is it possible this could become a problem? I would say the snapshot is not showing that right now. There I think have been only about 8 cases. The majority of those were in close quarters with a confirmed case with heavy skin-to-skin contact. So again, this virus is not looking to get in our pediatric populations and spread that way. It's really exploiting sexual behaviors.
Elizabeth, you mentioned how you know, we are all becoming sort of you know, junior epidemiologists, or at least some of us think we are, because we read a lot of articles and watch a lot of news, and that's reflected in some of these questions, such as if we are already vaccinated for smallpox, do we need to get a booster based on, you know, some sort of realistic concern?
If you're in a risk category, you should disregard any previous smallpox vaccination history. That is, that protection from smallpox vaccination is thought to be about 85%, but decreases over one's lifetime. So persons who have been previously smallpox vaccinated are being diagnosed with monkeypox at a lower rate, yes, but still possible. So disregard history of smallpox vaccination when considering your risk and need for vaccination with the Jynneos vaccinia vaccine.
And Elizabeth, so it seems like, based on what you said, Jynneos, which is a vaccine for smallpox, correct? But that seems to be working well for monkeypox. Might there be a vaccine that is developed for monkeypox?
I think that's possible. It's not on anyone's horizon right now with the vaccine that is about 85% protective. And also there are prevention strategies present, and most disease is mild. So altogether, I think we have a great tool in the Jynneos vaccine. And I certainly hope that people who heard something about themselves in the risk factors are considering access for themselves. You know, we really want to get this vaccine out. It's limited and we want to get it to the right people.
And question for you, one of our viewers asks about how or whether Dartmouth might be able to support students exposed to monkeypox off campus, overseas. You know, should that happen over the course of the term, and obviously it could, what kind of support would we be able to offer? Or is that just sort of a case-by-case basis?
Well, the students, all Dartmouth students have access to ISOS. And that's basically an insurance policy and an ability to get care outside of the US. So if people are on TUC programs or FSPs or LSAs, so different study abroad programs, they can bring their ISOS card, which everybody is eligible in the Dartmouth community to get. And then they can contact ISOS, and ISOS will tell them where the closest provider is that can help manage their problem. So it's difficult for us to manage overseas because we can't prescribe, we can't see, but we can shepherd. But all students have access to ISOS, which is a great resource for identifying who can care for them internationally.
You know, Elizabeth and Anne, as public health experts, and obviously public health experts who speak out publicly about issues such as monkeypox. I'd like your thoughts on this question, which is such a good one, and it's something that the three of us have talked about. One of our viewers writes in about how to balance the fact of the clustered risk groups, that men who have sex with men, against the possibility, and frankly, it's more than that in some cases, of heightened homophobia, transphobia, and other forms of discrimination. So how do you balance these very real concerns, and how do you suggest as a community we approach this issue?
I can start, and I hope Anne you'll pick up on the local approach to this. But I do want to say again, we are responding to the data, the epidemiology, what we know of this clustered group. Of course, we're recognizing that there's a long legacy of the phobias, as you mentioned. This is a very real legacy that will be difficult to overcome. And I continue to give this message that any person, regardless of gender identity or sexual orientation, can acquire and spread monkeypox. So this is a problem for all people. This is an outbreak that's affecting all of us. And we need to make sure we strike that equipoise between reporting the science as it is right now and making sure we hold that we're all human and susceptible to this virus, and therefore the actions we take today are important going forward. So let me pass off to Anne about the local approach to this real dilemma.
Yeah, I appreciate that. I think that's a great response, Elizabeth. I think we're also going to just work with our partners and the Dean of the College Division to really create a affirming message to promote prevention, and that all of us can be at risk, particularly with close physical contact and aggregate living. And so I hope we can have a supportive message. We definitely have populations of students already contacting us, hoping to get some support related to getting the JNEO. So I hope that won't be a predominant issue, Justin, on this campus.
As do I, Ann, and I think that's why these kinds of events are valuable, so that we can talk about the disease, talk about the virus, and deal with facts and reality. And to hear folks like both of you say the things that you have said, it's so incredibly important. As we know, words matter. What our leaders say matters and has an effect. So thank you both for being here and for saying what you've said. We are sort of running out of time, and the questions are slowing. I will ask one more question, and this is an interesting one again, sort of based on so much of what we learned during COVID, and it's about wastewater. And so, Elizabeth, this may be for you. Is wastewater being tested for the monkeypox virus, much as it was done for COVID, as sort of a warning system that it may be present in the community?
Indeed, for those unaware, testing wastewater, sampling wastewater from a building, from a community, using these highly sensitive molecular diagnostics can give public health authorities an early signal for disease transmission within that building, community, city, or what. This is with a lot of media attention right now, as we've transitioned the use of this powerful tool from COVID to another highly localized emerging infection in the New York jurisdiction, which is polio. So this is now being talked about as a way that public health can get an early signal for the circulation of polio, with the purpose of promoting vaccination when it's detected. We right now don't have evidence that there's transmission within our state without a clear chain of transmission, if you will. So we will take on expanding our wastewater testing as it's appropriate and it has actionable events associated with detection. So it may be that we are moving all toward routine surveillance of any disease in wastewater. But right now we are not using it for monkeypox detection, given our case counts and the fact that this may not change our public health messages of prevention and early treatment and contact investigation.
Very interesting, Elizabeth. Thank you. And thank you so much for your time, for your wisdom, for your care, for your interest, and for your commitment to the Dartmouth community and spending a little bit of time with us today. I really appreciate both of you. And Anne, I know you are just returned from vacation, and so we appreciate you diving right in, day one, back on campus, back in the office. And obviously we will do this again should there be a need, but I think we all hope that talking about it as much as we are and getting the information out that can really help people avoid, to the extent possible, developing the virus. Hopefully, that this can be contained in a way that is at a minimum manageable, and hopefully something that we're not talking about just as much as we are now. But I would like to thank you for joining us today, and I would like to thank all of the viewers for tuning in and sending in your questions. As Anne mentioned, there is a monkeypox page on the Dartmouth Health Services Dix House website. we'll be producing news items and more information about monkeypox as necessary. So keep on the lookout for all the places where you receive Dartmouth news and alerts. That's where you will find any updates on our response or what we know about monkeypox. But with that, I will thank you once again and tell you all to please have a good day. Goodbye.
Thank you all for joining.
Thank you.
Good day.